Terrific. Thanks very much. Welcome everyone to today's program. This is Richard Mala with the Long-Term Care Community Coalition. I'm going to start my video. Hi. A few meeting tips before we get started. Please put all of your questions in the Q&A at the bottom of the Zoom screen. We're going to leave time at the end of the program for Q&A. Unfortunately, we do not have capacity to take live questions, so please don't raise your hand. If you have a question, please put it in the Q&A. We also will be monitoring the chat, but not for Q&A. So if you have an issue, a technical issue, you can put that in the chat, and you're certainly welcome to chat in the chat. But for any questions that you would like responded to at the end of the program, please put them in the Q&A. A few items of interest at nursinghomes411.org, our homepage. We have a new culture change policy brief, whose author, Nina Loewenstein, will be talking today about her findings and about some of her insights, et cetera, which I think will be really interesting. We're also telling people, or encouraging people, to call on Senator Schumer to back the White House's proposed nursing home reforms. This is particularly focused in New York State, where Senator Schumer is from, but we do urge you all to please contact your members of Congress and your senators, urging them to back the White House's proposed nursing reforms. The two main lobby associations for the nursing home industry, both of which sit on tens of millions of dollars, are in DC now and will be in DC in the next couple of months, lobbying our legislators in Congress. So please make sure that your voices are heard. Nursing home residents don't have highly paid lobbyists. All we have are residents and families and ombudsmen and others who care about these issues from the resident perspective. So please make your voice heard. We also have a new policy brief, New York's direct care minimum spending ratio, and we are going to be coming out with a couple of new policy briefs as well. One on a direct care minimum spending ratio for nursing homes that is more of a national scope. That should be out in the next week or so. Latest issue of our journal came out a couple of weeks ago, and our new Elder Justice newsletter as well. And our last webinar, which was held in mid-March, A Matter of Justice, Racism as a Fundamental Cause of Long-Term Care Inequities. It was a terrific program, and I encourage you, if you didn't see it, to please visit our website or our YouTube channel to catch it there. Let me see if I can, there we go. Okay, my screen is working. So a little bit about LTCCC, for those of you who are not familiar with us. We're a nonprofit, nonpartisan organization entirely dedicated to improving care and quality of life for elderly and adult disabled people in long-term care, including people who are in nursing homes, assisted living, and other adult care residential settings. We focus on policy research and analysis, as well as systemic advocacy. But more and more over the past 10, 12 years or so, we've been doing public education programs such as this one. And we are also the proud home to 2 local long-term care ombudsman programs here in the Hudson Valley. And our website, of course, is nursinghomes411.org. We have a range of resources and information, all of which are free to use and to share. So today's webinar is called What is Nursing Home Culture Change? As I mentioned, Nina Loewenstein will be presenting on this. She just undertook months of research, really digging into the background of how do we make culture change happen? How do we set the guideposts for what we as consumers, as residents and families now and in the future want to see when it comes to culture change? And as I mentioned just with the last slide, this is part of some work that we are doing to help shape the envisioning of nursing home care. And we're, of course, really excited that this is something that is gaining movement both on the state level and with President Biden's latest announcement for nursing home reform on the federal level. Again, I'll say it one last time, please, please, please speak out to your member of Congress, to your US Senator, call the White House and tell them that you support real change in the culture of nursing homes. Before I hand it over to Nina, I want to talk a little bit about some of our perspectives on culture change. It's always been for me a a bit of a perplexing issue, because as someone who has studied the nursing home reform law and the implementing regulations for close to 20 years now, to me, the nursing home reform law from 1987 really calls for a lot of what we see in culture change. And it's not, a lot of it is not really something that should be pie in the sky or should be aspirational. It should be something that is realized in the rights of residents every single day now, for what we're currently paying and for what we're currently expecting of nursing homes. So very quickly, I just wanted to talk about some of those basic tenets just to plug in our viewpoint here. And these are some of the things that I put on the slide that are already part of what is required of nursing homes right now. And I know it's, a lot of these things are not what we see when we visit a nursing home, not what we see when we visit a nursing home, not what we see when we place when we enter a nursing home or when we place a loved one in a nursing home. But it's so important from our perspective for us to know what residents' rights are, and in order to be able to advocate as effectively as possible for that, including advocating for some of the culture change tenets that Nina will talk about today. But some things that already exist in the law and in the rules and have for over 30 years are the resident's right to make decisions and to be directing his or her own care the way he or she sees fit. Part of that, of course, a central part of that is informed consent. The resident has the right to know about any proposed treatment, any proposed medication, the strengths and weaknesses or the potential benefits and shortfalls of that treatment or medication, and the right to say no. And when I started, I was in my late 30s, around 40-ish, and I used to say, I like to make decisions for myself. And if I want to, for instance, have French toast or a bowl of cereal for dinner, that may not be the most nutritious thing, but that's my right to do it. And the same thing holds true now that I'm in my 50s, and I'm sure it'll hold true when I'm in my 60s and 70s if I live long enough, and so forth. It's that we as people always want to have the right to autonomy. And yes, a nursing home is a congregate living situation, and we have to be respectful and cognizant of that and of the others who live with us and of their right to live with dignity and to make choices and to live comfortably. However, fundamentally, the right to how I want to live, what I want to eat, when I want to wake up, when I want to go to sleep, whether I want to take a bath or a shower, etc., those rights do not go away when you enter a nursing home. And I know, again, it is a really tough thing to advocate for. I've been a family member many times, and actually am a family member of a nursing home resident right now. So I know how challenging and frustrating it could be. But based upon our knowledge of the rights and our knowledge of the rules, we can help to make it happen. So a lot of the basic tenets of culture change, again, already exist, are certainly all supported in nursing home rules and regulations. It's really just a matter of, implementing them. I just want to quickly introduce Nina. I've come to know Nina personally for goodness, I think it's about 1.5 years now, through work that we do together in the New York State Bar Association. We co-chair a partial committee, something. I never quite get it right, I apologize. But we actually work together on putting together educational pieces on nursing home and long-term care facility reform. Nina is also a staff attorney with the Disability Law Center in Massachusetts. And prior to that, she worked for many years with the Disability Rights Center, I believe I'm getting the name right, in New York State. So without further ado, I'm going to stop sharing my screen and hand it over to Nina.
Oh, hello, everyone. I think I may be a little blurry. Is that right?
Yeah, you are a little blurry.
Okay. The only way I know to solve this is to quickly leave this and rejoin. Can I use?
Okay. I'll talk for another minute.
I'm going to be right back.
Thanks, Nina. The beauty of technology. So before we get started, as I started to say, I'm just going to, if you all don't mind, talk about it a little bit longer. we have, we and of course others have worked on, so-called culture change issues for many years. And as I said, a lot of them are already required, are already part of the nursing home rules. Are you back, Nina? That looks good. Okay, then I'll stop.
Yeah, all right. Sorry if you were mid.
No, not at all.
Okay, so I just want to thank Richard's invitation to work on this project with the Long-Term Care Community Coalition. It's been a great thing to dive into, and it is, consistent with, I've always been a, client-centered attorney with disability rights projects in New York and in Massachusetts. And this really brings it home in nursing homes where so many older adults and people with disabilities live. And it's very much, the timing of the attention on this is really, for the devastation of COVID, in the wake of COVID, that, showed the, just terrible results of poor staffing, of lack of infection control, the quality of life. And there is evidence that in smaller homes, in homes with consistent staffing, including culture change homes, that this was, COVID was less devastating, although there certainly were deaths and certainly were infections, but that this, having staff consistently with residents, having smaller environments really made a difference. And so there is, our governor has made a statement, statements in support, and her plan for culture change. The White House has stood for nursing home reform and for some specific proposals that would facilitate culture change, including, the ability to finance private rooms. So now is the time to make the push. I'm going to just start with, this is a relatively short PowerPoint. And I'm going to go to okay. So I want to just start with a short definition of what culture change is. There are many components to it that we're going to get into more a little bit later, but it's a movement that's really seeking to transform the nursing homes from the institutional medical model settings to home-like, and I would say comfortable, because it's the quality of life, the ease, comfortable environments that promote residents' quality of life and choices. So this is just, kind of the soundbite version, but we'll talk about different elements. And in particular, I'd like to focus on the relational care that is such an important component of culture change homes. Now, culture change homes are a small kind of drop in the big bucket of nursing homes in the US, which are, over 15,000 homes, and many of them large, and the number of nursing home residents being over 1.3 million. And then there was a drop during COVID, but the rates of admissions have gone back up. So, roughly the culture change homes, the organizations that have homes would probably be a total of maybe 1,000, maybe a little more. But it's small. So that's just to give you a sense of kind of the scope. And so most nursing homes are this institutional medical model. And I want to just mention sort of how it got that way, because it's not as if this was some evidence-based approach in how to, care for our older population. In fact, it really was an offshoot of the vast building in the hospital system that happened it began in the mid-40s after World War II with the Hill-Burton Act and funding hospitals. And the people who went into hospitals were older people there were many older people who lived in in homes that there were old age homes that they were able to support with Social Security, which was pensions, which were relatively new. Many went into those hospitals, and people also entered from the community. And the hospitals needed to place people who needed really custodial, more support, but they weren't acutely ill, into other facilities. And so there was a bid to add the nursing homes under the Hill-Burton Act. So these nursing homes have followed many of these building standards, and so they are very hospital-like. The nurse's station in the middle of the unit, much as you'd have in the hospital unit. And with then the growth in the government funding of Medicare and Medicaid, you really had, this element just ballooned. But it wasn't as if all the older people needed round-the-clock nursing care. In fact, the recommended daily nursing could be less than an hour for an individual. So, some could be supported at home, but they didn't have the services, and many went into these nursing homes. So that was really this outgrowth of hospitals. And with that then it was a system that wasn't prepared to care well for all of the people who lived in the homes. So you had the tremendous problems with the quality of care, even though this was hospital-like. That's sort of the terrible irony of it. So if 30 years go by, and there's state regulation, but it's relatively weak. But really the push for the federal regulations that Richard talked about was, the Institute of Medicine that did a study that built on actually a survey of nursing home residents was part of what went into that study and what mattered to them. That was the National Citizens Coalition for Nursing Home Reform study from 1985. And much of what was discussed in the study, what the views of the residents, again, underlies the culture change tenets, as well as the individualized, the nursing home reform law, which then emphasized the individualized care that nursing homes should practice, the services they should provide. But so what came out of the survey, was the emphasis, the importance to residents that the attitudes of the staff, the direct care staff, the friendliness of the staff to them, that this was all highly important. The interactions that they have on their daily basis, that it's important that they're treated with dignity and respect, that they value close relationships, they value making their own choices and decisions and participating in care planning, and the quality of food, the variety of food is important, in remaining active, engaging in activities. So these are all, the notion of sort of a thriving adult is what comes through. And yes, so the nursing home reform law and the ensuing regulations tending to support that, but also from there, over the course, at least over the next 10, 15 years, the culture change movement, sort of a more radical look that really it's these hospital models. This is the problem. We need to change these environments. We need to take, the direct care person needs to be at the top of the, top of the chain, not at the bottom, because the hospital model is characterized by this hierarchy of staffing. You have the administrator on the top, you have a director of nursing supervising the direct care staff. So there's layers of decision making, typically very top down, and they're larger, right? And so there's something of an assembly line kind of tasking that goes on to fit into schedule. So all the residents need to get up by a certain time and be able to be ready for breakfast, or trays get brought into their room and the food on trays. Maybe it's been cold by then, but that the bathing, the dressing, there isn't the choice. The resident doesn't say, I want to sleep through this and get up at 9. They have to they have to go along. And the same with decisions about showering or whether to shower or bathe. It might not be a decision at all, and when to go to bed at night, the schedule of activities. So it's not a day that's planned by the resident, typically in the the typical what Gus call traditional nursing home. So that's what the culture change movement wants to turn around. And demedicalizing, changing the environment, the design, empowering the staff, building the relationships. And perhaps the earliest example in the United States was, or at least what sort of started more of the development of these models, was the Bill Thomas's efforts in the Chase Nursing Home, it's Chase Memorial Nursing Home in upstate New York, where he became the medical director in 1991. And he looked around at the nursing home, which was not one of the largest places, but I think it may have been about 80 or 90 people living there. But it was institutionalized, and he sensed this sort of absence of liveliness. And what the problems he identified were not medical problems, but the three plagues, as he called them: the loneliness of people, their sense of helplessness, and their boredom. These are called the three plagues. And these became part of what the Eden alternative grew out of this. And we'll talk about that. But so what Dr. Thomas wanted to bring in was sort of this cure for these afflictions and to bring life into the nursing home. And so he proposed to the administration bringing in animals and live plants in people's rooms, and starting a garden for fresh food and for flowers, and also bringing in children. So they would start a daycare for staff's children, an after school program. And the bringing in the animals required a waiver of New York State regulations, which they were able to obtain. So they brought in, I think the number may have been 100 or so parakeets. So there were a bird in every residence room, and they brought in a certain number of dogs and cats, and they had hens laying in the yard. So this was all supposed to be a kind of the big bang of change that, his view was you need to do it in a big way because culture is kind of an inertia. There's an inertia in it. Everyone's used to doing something a certain way. And if you bring in everything at once, it'll just sort of topple that. So, I'll just share the screen again and show you how this evolved. Oh, there's a representation of a resident in his room with the bird and the dog. But so this was actually studied by New York State at the time, and I haven't been able to find the study itself, but the report on that study was that there actually was a reduction in medications needed, and particularly medications to treat agitation, that there was really a good effect and a good outcome for residents. And there's sort of a nice description of all this. I think Bill Thomas has written about it, and I haven't looked up that writing, but Atul Gawande's book, Being Mortal, he interviewed Dr. Thomas and has a really, there's quite a great narration of how this all took place and the effects on people, and sort of how people came to life. And one gentleman who hadn't been eating and wasn't getting out of his bed started to talk with the nurse's aides about how the bird was doing, and then eventually got up and dressed himself and wanted to take the dog for a walk. And he actually left the nursing home and to live independently after that. So there are some really, the examples were pretty powerful of how this worked. And this nursing home, I checked it out, and to this day, they do have animals and plants, but they're not part of the movement that grew out of it, which was the Eden Alternative. They're actually part of the Good Shepherd system of homes. So so this is the Eden Alternative, just a summary of this network that was, founded from, inspired by the Chase Memorial as a solution to the 3 plagues. There are now 270 registered homes, and they are grounded on 10 principles that emphasize community, companionship, purpose in life, spontaneity, empowerment, the collaborative culture of the home, and a leadership that supports lasting change. They can be smaller units in a larger home. So a lot of homes will sort of break down their structures, sort of hide the nurses station, make neighborhoods out of units might be a way to do it, and interconnect to make a larger community. There isn't really an orthodoxy about the physical layout. These are just the 10 principles that are laid out. And this is all accessible on their website. But the point is that people can thrive, the environment, and that everything that's done is to bring more meaning to someone's life, to put them at the center of decision making. And points 9 and 10 is something that I'll focus on in all of the models, but that the collaborative, resilient culture is a never-ending process. You can't just leave it there and let it and assume it's going to keep going on itself, but that the leadership has to kind of keep promoting it and reinforcing it. These are the domains of well-being that the Eden Alternative, the goal of these principles. So now the early studies of the Eden Alternative were rather mixed and small studies, and as to how effective it was. And I think, it's just difficult to kind of do traditional research on culture change. There's just so many components and things. It's multifaceted, and maybe it was simply an impatience with the research, but Bill Thomas went on from this to found the Greenhouse Project, which was to build from the ground up and to completely get away from the larger facilities, which could be, that can be a block to change. So it can be harder to transform. So he wanted to build from the ground up, and the Greenhouse Project commenced following the Eden Alternatives. That began in 2001, and these are, this is now probably the best studied of the culture change models, where each home has a private room and private baths. They're located around the living area with the hearth, the open kitchen and dining room, and there's easy access to the outdoors. And the elders decide on daily schedules and the care plan. This is the ideal, right? And that they're at the center of the collaborative decision-making for the house. So around the elder are the Shabazim, who are the direct care workers, and they work both close. They're consistently assigned. They're work with the same people day to day, and they in themselves are also do their teamwork between. These are shifts that need to coordinate and manage the house. So their duties are versatile, and it's not only the personal care, but cooking, planning meals, managing the daily operations of the home and activities. And the reality is that they may not be able to do all these things. That it, you know, some of the things that slip are, for instance, the activities. They can't necessarily go out on as many activities as perhaps could happen in a larger home. So some of these models, they remain attached to so-called legacy homes. That's the larger traditional home. And there can be some cooperation with the activities done from the larger home. So, so they're not necessarily sort of standalone. They can be connected with the larger institution. But the importance of the personal care is that consistent assignment, how collaborative they work, and collaboratively with the clinical team, which is less visible. They may be coming in from the outside, so you might not have a nurse in the house all the time, but they would be on call. And the last sentence of this summary is about the guide, which may be the administrator that works from, again, the outside of the home and supervising the work, or coming in to, you know, coach on solving a problem or handling an issue, but that the goal is to be promoting the Shabazim as the managers of the home. So this actually took many of the components of an earlier model of culture change, which is also you know, a dominant, I mean, as far as a dominant model in the United States, the household model. So they're very, you know, smaller homes, the privacy, the dining table together, access to the outdoors, and caregivers that are referred to as care partners. So that's also an active model of change that is similar to the greenhouse, but not as prescriptive of physical model. So I think with that, it would be nice to see a video of, this is from the first move into a greenhouse. So it's in 2003 in Tupelo, Mississippi, where the elders who move into the home actually are coming from a larger home, which turned out, I learned later, an Eden alternative home. They move into a greenhouse home. So Eric, if you want to show a few minutes of that.
In the greenhouse, people are coming there to live, not to die. And we believe that anybody, regardless of frailty or mental capacity, still can continue to grow. And that's what the greenhouse does. It's an environment that enables that growth. Anybody walks in the door, it's one of those, yes, this is what it ought to be.
You smell like good cooking they're doing.
I'm glad that you're able to
cooking you a good meal.
When you walk in the door, you smell breakfast cooking. You smell the coffee.
We want the aroma of the food to come out. Well, that's why we're constantly having some baked goods, because aroma goes through, it makes them hungry, that increases their appetite, they eat better. Kitchen is a gathering place anymore, and even so, with these homes, I see the elders gathering around the kitchen, hanging around the counter, just watching, asking questions.
She's smiling.
They sit down at the family table. They talk about what happened during the day. We serve them the soup, then when they're done with the soup, we clear it, then we serve the next. There's no hurry that says, fine, you got to be done by 12:30 because I've got to go do something else. No, if it takes 2 hours, it takes 2 hours to eat. It's relaxed, and we want the Shabazim to sit down and enjoy the meal with them. You know, they say, I like my meat done a little bit different, and someone's going to be there. Okay, let's try that next time. We want to have a picnic tomorrow. Yeah, let's have a picnic. Okay, so Saturday we'll grill hamburgers and hot dogs.
That you can sleep late if you want to. Don't have to. Everyone doesn't have to have the same breakfast every morning, or the same lunch, or the same dinner. That kind of facility is just, I don't know why we haven't thought of it sooner.
I love to come to work every day. It's an experience to see people getting back, like I said, some of their dignity. Some of them wouldn't even eat. They come in the nursing home, they sit there at the table and fall asleep, and they wouldn't even eat their food. Here they're eating, they're talking, they're drinking, they're having dessert. It's great.
She's eating much more since we moved down here. I think they said she had a 4-pound weight gain last week. Up there, she'd just go to sleep and maybe fall over in her plate.
Within an hour of the move, at her first meal in a greenhouse, Mildred stunned her son by taking the spoon away from him.
I started out feeding her just a while ago, because she's been fed, for the last several months, but she took the spoon away from her.
She did?
And she started feeding herself.
Great.
Have a good meal.
That's just what we're thinking is going to happen here.
It's just amazing that she's doing this. She has not fed herself in months, really. And today she wanted to do it. It's amazing.
Mildred continues to feed herself and is speaking more.
You got any that's hot?
Okay, do you want sugar or cream?
Such improvement is common in the greenhouses.
We had an elder here named Miss Stubblefield. She hadn't been out the bed, and now she's up and in her wheelchair, and she's in here every day when we're cooking supper, and she's talking about her recipes, and it's just wonderful.
The ones that were in wheelchairs are now out walking around. It amazes me. I love it. Their smile on their faces, the expression on their faces are totally different. Totally different.
How you like it?
I like it.
I knew you would.
Isn't it nice? It's just all the comforts of home. And nice people.
We want to create.
So that is how it can happen. I don't think that most greenhouses have chefs, but typically the Shabazim are preparing the meals. And earlier in the film, the Shabazim talked about the different trainings that they would have to take on different duties in managing the home. And Bill Thomas appears in that, and he talks with the son of the woman who started to feed herself. So, the big question is, how can this be sustained? So we'll just take a look at sort of the common elements of the greenhouse, or not the greenhouse, but all the models. So the resident choice, the self-direction, the home-like environment, the close relationships between residents and staff, the empowered direct care and other frontline staff that respond to residents' needs and desires, and how they interact with the clinical staff, the collaborative decision-making between the staff and between the clinical staff, and the social engagement and community. And that can vary between the models. The greenhouse may have less of that than an Eden alternative that has units that might be, all combined to share. There's an example where there are many homes that share a common internal street. This is in a Canadian home that's a cold environment. So they have the shelter of this internal street by all of the smaller homes, and then they can go on to a gift shop or an art studio kind of thing, where you have the resources of the larger organization, but everyone can live in smaller enclaves. So that models can emphasize some elements. I think that social engagement and community in particular can receive more emphasis in some models than others. But what really comes down to in common is the resident choice through the direct care workers and that collaboration. So before the Pioneer Network is this is the last slide. That's a coalition of long-term care providers that came out in 1997 to promote and advocate for person-centered care and culture change in U.S. nursing homes. And that hosts an online resource library. Actually, so you can see here, there are many things on this website that are really, really useful. There are videos and other kinds of tools. And they also sponsor state coalitions. So I just wanted to mention that very helpful resource. So what went a lot into this policy brief were sort of the examples of culture change and how that practice is sustained. You know, because these are congregate settings, so how can resident choice be accommodated among, you know, for many individuals at once, even if it's, you know, 12, 15 as opposed to 35. So, you know, again, it can, having the staff with the residents, if the staff know the residents and work together, they can solve the problems of, you know, on a dementia unit, for example, how to help keep a resident calm who is often anxious or crying, how to keep an animal in the home where one resident wants to visit with it, whereas another is bothered by it, or a bird that, you know, chirps and disturbs a resident, but others want to care for it. So there's a lot of examples in the day-to-day decision making that that direct care staff, if they're empowered to manage the situation, they learn from the knowledge and also the social relationship that they care for the residents and the residents care for them. So they want to solve the problems in a way that works well for all. So, you know, one of the examples of that came out of studies on the greenhouse where the really looked at, you know, how are the principles reinforcing care. So one of the researchers that we cite in the brief is Barbara Bowers, who did a lot of observations and interviews of the direct care staff and the clinical staff and administrators. And she observed, you know, situations such as the Shabazim at a greenhouse grow frustrated because the various shifts haven't coordinated in stocking the needed resources of the washcloths and the briefs and the things that are needed day to day in the home, and they're not available where they're needed. So there's conflict that develops among the direct care staff. They don't want to be without these, but they want enough available and not too much to make the homes look institutional. So they have to coordinate between the shifts and how to resolve the stocking of these resources. So the outside guide helps to coach them to brainstorm and problem solve, and they're able to come up with a system between all the shifts of stocking so that the home continues to look and function like a home, but the staff have what they need. And so, you know, that coach collaborative approach is what sustains the model. And if there'd been sort of a top-down decision of you have to do it a certain way, you wouldn't have the buy-in, the buy-in of the staff and their decisions, and you might have a more institutional look that would be contrary to the preferences of the residents, versus, you know, an erosion of a greenhouse decision-making model. And it's not just the greenhouse, but small houses, household models, even alternative, could be characterized by reverting back to traditional institutional ways. For example, a medication cart starts to come into use again for the convenience of staff, whereas this sort of thing would have been, would have disappeared from the home because it's not home-like. I thought, Bowers had pulled out, I think a helpful example, because it really is challenging, of where the model slipped, and this concerned an elopement from a home where the elders were seated in front of the home on a front porch that's like nice weather, they're enjoying the weather, and then one of the elders leaves the porch and wanders off towards the road, and he's found and brought back to the home, apparently not by someone from the home, but he's found and brought back. The administrator reports this to the state authorities as an elopement and has to come up with a solution in 24 hours to involve, to address to correct the deficiency, to prevent elopements and escapes. So, but instead of gathering with the Shabazim to come up with a solution, because it's sort of considered this time-limited problem, they decide, well, we're going to have to put alarms on the outside of the house. We can't have people out on the porch without supervision. We have to have the residents sign out before they leave. And so they start to put into place what is more an institutional characteristic. And apparently the Shabazim had other ideas, which actually weren't explained in this article, but which one could imagine. For example, maybe you build a fence or do something to make it a more self-contained residence with outdoor space that would be more difficult to leave, but because it would be large enough, that wouldn't detract from the model. But it was handled in a hierarchical way. It was handled under pressure or perceived pressure. But there wasn't, the time taken with the staff to how to honor the model through this. And the sense was it could have been done. So, it became clear that the way to sustain the model is for the leadership to be consistently committed, and it's a participatory kind of leadership. It's not sort of the, typically we think of leadership as, very visible and showing, making those decisions, but it's really a leadership that promotes and coaches decisions and decision-making, so that the people who spend the most time with the residents and with the elders are empowered to use their discretion. And, this can come out in all kinds of ways. So, those dining examples, that was in the greenhouse in the film, but there are many ways in which dining comes up as a way where culture change can happen. So, for example, if the population in this home, is their culture, maybe if they come from an Asian background, they may choose to have, soy sauce and with their cooking. If the home takes that off because it's too salty, they're detracting from the quality of their meals. And it's up to be the direct care staff that would express the preference, or the people who do the cooking. They can be brought in if they know the residents. They're less likely to simply take away something that's seen as a nutritional problem or a risk. How do you handle risks in balancing these choices? So that is, a key way in which culture change, it's a constant implementation. So I think that the only thing I'd like to mention before sort of turning to some questions is also, that this is to mention the self-assessment tools that can be very valuable for sustaining a practice. The greenhouse home has such a tool. but not all of the homes use it, but it can be a very valuable way for staff to provide input and reflection and to sustain a practice. So I think that, one of the the main concern with how do we promote more greenhouses and other culture change models really is with their cost. Is it more costly? What is it to build a home from the ground up? And the capital costs are real for these culture change homes. They have more space per resident. And often the main participants in culture change have been better resourced. So they come from foundations, they may be they have foundational support. They may be a nonprofit religious organization that has foundational support or non-religious, but this has typically been where the culture change model sits, or they have retirement communities that have private pay. So I think, the analysis of the greenhouse is that it is more primarily middle class, although there is some Medicaid. It's less than half Medicaid compared to the traditional homes where it's more on the order of 65%. And I think that's really a big challenge of how to make this equitable. I think, those incentives for primarily a for-profit system is, the transparency has to be there. The commitment to sustaining and reinforcing has to be there. There's really, you can't cheat on this. And I think, the push for the National Demonstration Project that was promised in the ACA would be a great contribution. Push for, the providing funding for more private room settings are all, using civil monetary penalties, which actually is commonly used for culture change and person-centered practices. These are all things to look at, and we discuss more at length in the policy brief. So it'd be great to turn to some of the questions that have come up.
Thanks so much, Nina. Just one second, I'm going to share my screen again. I don't know why. Here we go. Maybe that would be better. Okay. Thank you. So before we move on to questions, we do have many of them. I just want to put in a plug for our next program, which will be April 19th at 1 p.m. Eastern. It's called Picking Patients for Profit, Admissions discrimination, in nursing homes. And we have a guest speaker, health economist from UCLA, Ashvin Gandhi. And to register, you can see, if you go to our website actually and look at the webinars, you could register there, or there's a bit.ly/NH-discrimination. But you could always go to our website, Nursing Home 411, to catch the recording of this. It'll be up in the next couple of days, this program, or to register for a future program, or to see any of our last programs. As I just said, head to Nursing Home 411 for today's program, as well as more on culture change. I just wanted to piggyback on a couple of things that Nina said before I open it up for questions. One is really the incentive for us doing this work. And as I mentioned before Nina got started, Nina wrote this policy brief on culture change, and we have a number of materials that have come out or that are coming out related to nursing home reform. And those include better financial accountability and better transparency of nursing home operation and nursing home funding, which I think also gets to some of the questions that were raised and which Nina talked about as well, regarding where does the money come from this. But a big incentive for us to move on this now was because, as we were emerging and have been emerging, I should say, from the pandemic, we saw that there was, I think, a renewed outcry and movement towards reforming nursing homes and making nursing homes better, not only in terms of quality, but in respect to being a more humane place to live and to get care and to work. So I think that that is really important. What we wanted to do, particularly with the policy brief that Nina just put out, was to put some parameters around it. As I said at the start, there are certain tenets in the nursing home reform law, in the regulations that have been in effect for over 30 years now, that we believe support. No, we don't believe, they do support culture change, and they do support a more humane setting for both residents and care staff. And the question is, how do we implement that? So I'm going to open up for questions now. If you are a long-term care ombudsman and if your program provides credit for attending this as a training, please take a quick survey. It's surveymonkey.com/r/LTCCC-LTCOP1. And if you are a long-term care ombudsman program and you would like to and if you'd like to provide credit, just let us know. We'd be happy to add you there. So I'm going to open it up to Q&A if it allows me to do that. There we go. Okay, so our first question is from Janet Brennan, and she writes, if the culture change concept enhances the quality of life in the nursing facilities, how can culture change be a catalyst incentive for addressing the inadequate staffing levels so that there is staff in sufficient numbers to promote this quality of life while also promoting enhancements in quality of care? I don't know if Nina, if you want to take a stab at that.
Yeah, the staffing is so critical. I think that culture change should be, leading leading the advocacy for higher staffing, and that we need laws like the one that the governor is currently suspending, requiring for-profit to be devoting those resources to staffing, especially the direct care, and unfortunately, I think what a home with a staffing structure in place already would need to do is to cut back on kind of the administrative staffing and put it more into the direct care, which eventually do more management. But that should be leading that, I think.
Yeah, absolutely. Yeah, and of course, I agree. I mean, that's what we get at in the brief as well, is that really staffing is foundational in order to sufficient staffing that are trained, staff that are trained, and staff that are supported is really an important foundation for culture change. Thomas Wicker asked, I have experienced culture change as an ombudsman, licensed nursing home administrator, and as a family member. Due to insufficient resources, training, pay, supportive environment, and a flawed plan, hospitals, we find ourselves downsizing the nursing home industry as an answer with culture change in decline. Should we rebuild skilled care settings or mobilize skilled care into multi-setting service? If we rebuild nursing home settings, how is the rebuild better? Well, I'm going to give this to Nina, but I would just quickly say that they're not mutually exclusive. You can make nursing homes better and also make more options for people to get care and care that is of high quality and that's delivered in a humane way in all different settings. But Nina, I don't know if you wanted to. I
like the multiple setting idea. I mean, one of the problems is it's become so segregated, and they're actually there are great examples in some of the literature we refer to, and wanted to mention, there's one of the really leading researchers in reinventing long-term care, Pat Armstrong from York University in Canada. She looks at promising practices and has some great examples of sort of combined settings where, you know, the nursing home is not is not large and off by itself, but it becomes part of a community and a community of services. But, you know, I mean, this vision of nursing homes being built back better is, it would have to start with the resources and the plans, and we don't have a great way, I think, for government to be jump starting it all in this country. So I don't know. I think my imagination fails me when it comes to the government. Did you have anything you wanted to add, Richard?
Yeah, I would just say that reminded me that what Nina did over the last, I would say at least 6 months or so, was do a lot of literature review. That's where she really started off here. And so when she mentions Paula Carter, actually it was Pat.
That stuff.
Yeah, thank you. That we have gone through and we are putting up resources on our website. So we can't post the actual articles if they are copyrighted, but we do post, so we will be posting links, and that's also included in the policy brief as well. What we really wanted to do here is, I think, get the ball rolling in a renewed way in terms of thinking about policy and thinking about how to implement it, and doing some of the legwork in terms of the background research so that others don't have to, especially if we're looking at state funding through civil money penalties, or state/government funding through nursing home reimbursement. It's 2:01, so I'm gonna just go quickly. This Bridget St. John says, how does this model continue to work in a pandemic? Nina, do you have a quick response for that?
Well, the greenhouse and other small house models did function in the pandemic. That there's an article from Cheryl Zimmerman about the COVID rates and infections, and the social component remained more alive in those culture change models, so they were not as dismal places to live, which may have, you know, contributed to people staying well. But they, you know, they were able to sort of facilitate visits and so forth. So we know that the models, you know, the models survived the pandemic. I'm not sure what, you know, yes, it's less, there may be more, and I think the protections that have been, the direct care staff learn to protect themselves and have the resources, and they should be able to continue fairly well through, if there, you know, if there's another kind of lockdown within a facility. But I think they're more creative about how to continue to, with people's lives and day-to-day schedules and choices. Sort of the way the model meets the challenge is the key of sustaining the model. And there, you know, that's why I gave the elopement example as a, you know, it was a tough situation, I think. And the model, you know, they didn't sustain through that. But yeah, the pandemic presents plenty of challenges.
Thanks. Janine Ferrari asked, is the video part of current nursing home administration training program? Not, I mean, it may, this video is not, obviously, but you know, whether these materials are or not, that is a good question. I would ask, of course, the administrators that. There were a couple of questions just very quickly, because we're at 2:04, regarding financing and how this is paid for, Medicare, Medicaid, et cetera. It's, you know, as I mentioned, you know, when I was introducing Nina, the nursing homes now, you know, most nursing homes, as Nina mentioned, do not do culture change, or do not implement even, you know, even specific portions of what we would consider to be changing the culture and making the setting more humane and home-like for residents. But a lot of that is due to the fact that there is virtually no accountability for how the monies that go to nursing homes are spent. So Nina mentioned a couple of both state and federal initiatives to change that and to address some of these burgeoning gaps in what we know where the money goes and when for nursing home care. And so I think that we can certainly see, if nursing homes were required to put a certain percentage, a meaningful percentage of the money that they receive for resident care on resident care, I think we would see many more individual rooms. We would see better food because it wouldn't be so easy to cut back on food. We'd see the staffing that is needed because it wouldn't be so easy to cut back on staffing with impunity. So there's a lot of money that goes into this industry, a lot of money. What we don't see is the accountability, and therefore we see a lot of money really pulled away from resident care. Yes, Nina, I'm sorry.
There was a question, and I think I've typed something in response, but does this apply in dementia care? And I thought I think it's really important that yes, it does. And that, that person-centered care is very important for dementia care. And so we had put in a study into the policy brief that addresses how there was actually a study done of culture change and the reduction in antipsychotic drug use by, it was increasing, was sort of easing up on those schedules, making it more relaxed, and focusing the staffing more on the residents. So that was and many of these examples and many of what Pat Armstrong writes about concerns, dementia care. So I think it's really an important important piece of it, that this isn't just for people who are, can express all of their choices, but that it's very much alive for that. So yeah, take a look at the brief. There's some good examples from dementia care units. So yeah, I just wanted to.
Dave, no, I'm so glad you mentioned that, Nina. I would say just one thing I wanted to mention or repeat what Eileen Bennett, hi Eileen, said. Culture change can occur in any quote unquote style of long-term care setting. The nothing about me without me philosophy does not cost a dime. And I think that is a really good point on which to end. Bob kind of gets to Bob's question that follows next. But thank you all very much for joining us. Again, this will be being recorded, and it'll be available on our website in the next couple of days, our YouTube channel. And thank you so much, Nina, for your work in this area. We very much appreciate it. Wishing you all a very good afternoon.